Our last subject in the area of subcortical anatomy and clinical neurology is on movement disorders. All right, so last time we talked about white matter diseases and now diseases of the basal ganglia. So we've been over the anatomy of this, so I'm not going to, these are quick reviews, so if you want more detail, you can go to the more detailed lectures on movement disorders. But as a big picture, of course, in Parkinson's, among other things going on, we have a degeneration of the pars compacta in the substantia nigra, which results in less stimulation via the direct pathway and less inhibition of the indirect pathway. Okay, and cumulatively, that results in more inhibition to the thalamus, especially the ventral anterior nucleus of the thalamus, and so we shut that down, and so there's less glutamate going back to the cortex. Okay, and so that's kind of why this model is helpful. Less stimulation of the cortex, we have a hypokinetic movement disorder like Parkinson's disease. In contrast to hemibolismus, where we have a stroke of the subthalamic nucleus, so therefore we have less glutamate going out to the internal segment of the globus pallidus, and therefore less GABA inhibition, so more glutamate going back to the cerebral cortex. And now we have a hyperkinetic movement disorder like hemibolismus. Okay, so it is important that we separate these two, and we'll start out with hypokinetic movement disorders, which are things that look like Parkinson's disease. So Parkinson's disease, the most specific feature is the rest tremor. So if you see someone with a rest tremor, it is most likely going to be Parkinson's disease. And that is the first symptom in more than half of patients, but that's not what is disabling. Rigidity, so remember the TRAP are we can fit most of the clinical features of Parkinson's in one of those four categories. So T is for tremor, R is rigidity, and remember, unlike spasticity, this is not upper motor neuron. We don't have hyperreflexia and clonus and all of that, but it's an increased muscle tone that is not velocity dependent. So no matter how fast or slow you move the limb, it always feels stiff. Cogwheeling is just the feeling of tremor. When you're checking for muscle tone, you feel the tremor on top of the rigidity. The disabling features fit in the category of akinesia or bradykinesia, which means a poverty of movement. So everything slows down. The swallowing frequency slows down and patients drool. Patients are noticed to have not much facial expression. They don't blink as much. Any fine motor task is difficult. So handwriting, classically, the letters get very small. Anything like using tools, teeth brushing, shaving, all of those things are affected. And I should have mentioned with the tremor that Parkinson's disease is very asymmetrical. It's one side of the body that's predominantly affected. So the tremor, at least for the first year or two or more, is going to be much more seen on one hand. And then it may start on the other hand, but it's always going to be very asymmetrical. The voice becomes soft. Patients have a hard time rolling over in bed, getting out of chairs. They have to push up to get out of a chair, and their step size decreases. And the spouse will often notice they don't walk as fast. Now, important postural instability, and especially falling, is a late manifestation. So if we ever have someone we're thinking it's Parkinson's, but the first symptom was falling, then it probably is not Parkinson's disease. And over time, patients may have gait freezing, especially when walking through a narrow space like a doorway, when their feet just kind of lock up. It's important when we watch patients walk that have Parkinson's disease that you not only focus on the legs and the shuffled gait, but they don't swing their arms. And so the more affected side of the body, that arm especially, will not swing very much or not at all. All right, but a lot of other things go on in Parkinson's, and these are all very common. So depression, anxiety, dementia, importantly, occurs later. That's not an early manifestation. Okay, dyskinesias is something you only see when you give a patient dopamine therapy. Okay, because there's less dopamine, so dopamine receptors are upregulated, and so then when you give a patient dopamine, they have these extra kind of writhing movements from excessive stimulation of dopamine receptors. But if you see dyskinesias, like you're not sure if someone has Parkinson's, you give them a dopamine medication, they have dyskinesias, now you know for sure they have Parkinson's disease. That's quite a specific feature. So constipation, seen in more than 90% of patients. Seborrheic dermatitis, very common. Dystonia, which is a sustained muscle contraction, like curling in of the toes or twisting in of the foot, is very common. Loss of smell. And with any synucleinopathy, and Parkinson's disease is an alpha synucleinopathy, we have REM sleep behavior disorder, where patients act out their dreams at night and can be quite violent. So really important here, atypical features. If we see early dementia, then that might suggest something like diffuse Lewy body. If we have very prominent early autonomic symptoms, so the patient is passing out when they stand up, that would suggest multisystem atrophy. Early falls could be seen with both PSP and multisystem atrophy. Hallucinations, we'll discuss medications for Parkinson's which do cause hallucinations, but hallucinations are an organic part of diffuse Lewy body disease, so they get that even before there's any, even before you put them on any medications. Okay, if we have abnormal eye movements, that usually suggests PSP. If patients have ataxia, then that would suggest multisystem atrophy. And then a big red flag would be just not responding to medications. So patients with Parkinson's early on respond great to medications as a rule. So of course we see here normal pigmentation in the substantia nigra and a significant decrease here, and then we see Lewy bodies. And so interestingly, you need to have lost a lot of these, 50 to 70%, before clinical symptoms develop. So it's felt that the onset of Parkinson's occurs somewhere between 8 to 12 years before patients have any symptoms. So in terms of treatment, carbidopa, levodopa, and you need to know why we give carbidopa. Okay, carbidopa by itself does nothing, all right, but if you just give someone dopamine, they get very nauseated, they're going to throw up. So carbidopa inhibits dopamine decarboxylase, okay, which allows the levodopa to get in, cross the blood-brain barrier, where it gets converted into dopamine. Okay, and if you don't give carbidopa, then it just gets broken down peripherally, and the patient's going to have a lot of nausea and vomiting. So levodopa is the most effective treatment early on. Patients do great. You can not do a good job at putting them on the right dose or whatever, but they still improve. All right. Over time, though, it becomes very tricky because the medication will work, but then it wears off fast. And so you get these on-off cycles where the patient is moving well after they take their medication, but then they crash. And oftentimes then you need to give a higher dose, and then they get more dyskinesias when they're on. And then they're off and they're frozen. So most common side effects of both levodopa and, as we'll see, dopamine agonists are nausea and vomiting. Remember, dyskinesias are just very characteristic side effect of dopamine therapy. Okay, so in general, how do you decide whether to use carbidopa, levodopa, or dopamine agonists? So in general, if someone is over the age of 65, we're going to start with levodopa. And the reason is dopamine agonists are more likely to cause confusion than carbidopa, levodopa. And so if we have someone younger, the current preference is to start with a dopamine agonist. Okay, so a lot of review books still list bromocriptine, but no one uses bromocriptine to treat Parkinson's. It has more side effects, it doesn't work as well, and so pramipexole and ropinirole are the two dopamine agonists that are used. And these are very effective, right behind levodopa in terms of effectiveness. And so the reason we'll use that in younger patients is if you just start out with levodopa, you do prime patients a little bit to have more dyskinesias. So we usually try to save the levodopa in younger patients. So these are agonists at D2 and D3. They don't do much at the D1 receptor. Again, nausea and hallucinations are the two most common side effects of both levodopa and dopamine agonists. So again, dopamine agonists are a little more likely to cause confusion. That's why we don't really like to prescribe this in patients over the age of 65. We often will, but we'll warn patients about the possibility of confusion. This one will be very important to remember. Impulse control disorder, like gambling, addiction to online gaming, pornography, sometimes eating disorder, or sexual dysfunction. All of these can occur when we put someone on dopamine agonists. So really we like to have the spouse there at the visit to also, just confirm that we're not seeing any of those features. Much less common, but dopamine agonists can cause these sudden attacks of sleep. This is not a I am drowsy kind of thing like most medications. Patients just will suddenly fall asleep. And so if someone has that on dopamine agonist, you're going to stop it. Okay, again, dyskinesia is just like with levodopa, but levodopa is more likely to cause dyskinesias than dopamine agonists. Okay, so we tend to emphasize here the connection between the pars compacta and the striatum. All right, but remember there are also connections here with the cortex, mesocortical, and also mesolimbic. And so the hallucinations and the impulse control disorder that we see with dopamine agonists are due to these kind of excessive stimulation of these mesolimbic connections, especially with the nucleus accumbens. Okay, so remember that's kind of the addictive part of the brain. And so abnormalities here, abnormal excitation via dopamine agonists, will give us that impulse control disorder. Now, next class of medications, which really should not be used very often, are anticholinergics. So these block acetylcholine of interneurons in the striatum. And so trihexyphenidyl and benztropine are two that are commonly used. It does work well for tremor, but it doesn't work for any of the bradykinesia features. And remember, bradykinesia, that's the disability. The other reason we don't like to use anticholinergics, because it really only helps for tremor, is because just think of using an anticholinergic in an elderly patient with Parkinson's. They may have some dementia, which anticholinergics are going to worsen. More than 90% of patients with Parkinson's are constipated, and so you're going to make them more constipated. And so that's why practically we really don't use these very much. Now we can use medications. Here remember the catecholamine cascade, all right? So we can use medications that would inhibit the enzymes that break down dopamine, monoamine oxidase and COMT. Remember though that enzymatic breakdown of these neurotransmitters is relatively minor compared to reuptake, like with acetylcholine. There the enzyme is really important. But here these are relatively minor in terms of inactivation compared to reuptake, but they do have some benefit. So rasagiline is the MAOB inhibitor that is used now. Selegiline is still on the market, but I think people are almost exclusively using rasagiline. So it does break down. Here we can see dopamine being released, stimulated dopamine receptors being taken up, and here it gets broken down by monoamine oxidase B. So selegiline or rasagiline inhibits that. So you get a little more dopamine. Very, very mild benefit. Many neurologists I know don't prescribe this anymore because it just doesn't do a whole lot. Now, a COMT inhibitor, however, entacapone, this can be quite useful in our treatment of patients with Parkinson's. It does nothing by itself. It must be given with carbidopa-levodopa, and basically it extends the action of levodopa. And so its indication is if you have someone wearing off. The carbidopa-levodopa doesn't last as long as it used to, and they're going off, they're frozen. And so adding entacapone to levodopa can be helpful for that. So it's only for wearing off. Amantadine is an antiviral agent that probably acts by increasing dopamine release. It may block a little bit of dopamine reuptake. It helps a little, very mild. And its main use now, interestingly, is if you have someone with dyskinesias due to levodopa or dopamine agonists, amantadine actually is quite effective for taking the edge off of the dyskinesias. So that's its main use. Now, after that, if someone, they've had a good response for a long time, but now we just can't do much more to help them with medications, then we would consider deep brain stimulation. Okay, so a probe is put in one of two areas of the brain, and then it can be adjusted when patients come back at follow-up visits. You can adjust the electrical stimulation. Actually, it inhibits that part of the brain, so stimulation, that word is a bit confusing. And so basically these are put either in the subthalamic nucleus or in the internal segment of the globus pallidus. And as I understand it, it just depends on whether you're on the west coast or the east coast in terms of whether you're going to have it placed in the subthalamic or the internal segment of the globus pallidus. And jury is still out in terms of which one is better, but they're both very effective. Now remember that patients with Parkinson's, if they get demented, if they need a neuroleptic, you can't give them a traditional first-generation neuroleptic that blocks dopamine, because that's going to make their Parkinson's much worse. So quetiapine, and there are some other options, but I would say this is the one used most often because it doesn't do a lot with dopamine pathways. And so this can help someone, for example, that has hallucinations. Now, Parkinsonism refers to the patient has features of Parkinson's disease, but there are some different features. And so probably the two most important here in terms of neurodegenerative diseases would be progressive supranuclear palsy and multisystem atrophy. So remember I said with Parkinson's, falling is a late feature. So early falling would suggest PSP, and these patients have a very classic eye movement problem. And it's initially with downward saccadic eye movements. Remember, a saccade is a quick eye movement. And over time, it just gets worse and worse that they have a really great inability to look up and down. And it can eventually affect side-to-side movements, but it's mainly vertical gaze. They also develop a dementia, kind of a withdrawn, depressed-appearing, demented patient. They don't respond very well to medications, and they frequently will have pseudobulbar palsy. All right, so prognosis is not very good with PSP, and they do have, it is a tauopathy, and at the end here I'll list all of the different tau diseases. So if we do an MRI scan, and oftentimes radiologists will miss this if you're not really looking for it, but we have midbrain atrophy, which we can see here. Midbrain is much smaller, and you can see this kind of looks like a hummingbird here because of the atrophy. So that's called the hummingbird sign. The midbrain here, the space around it is much bigger than it should be. So we have midbrain atrophy. Remember, the midbrain is important for vertical eye movements. And so that's why we have a preferential involvement of vertical eye movements. MSA usually happens in younger individuals. Okay, so early, mid-50s. They have Parkinsonism, but the key feature here is they have early, profound autonomic disturbance. And the old term for that is shy-dragger syndrome, which I only mention because boards may still use that. So Parkinsonism with early passing out. Now, someone with advanced Parkinson's who's had it for years will also have syncope and passing out, and oftentimes the dopamine medications can make that worse. That's not multisystem atrophy. Okay, autonomic disturbance occurs early in multisystem atrophy, unlike Parkinson's disease. Now, the other, about 80% of MSA is Parkinsonism with orthostasis, shy-dragger. About 20% will have the ataxic form. So the older term you don't need to know is olivopontocerebellar degeneration. And so if we have ataxia with Parkinson's features, we would just lump that in and call it multisystem atrophy. Okay, so again, early falling, like PSP, they get worse, they don't respond to medications, significant autonomic instability. Like PSP, these patients also have pseudobulbar palsy, and this is a synucleinopathy, like Parkinson's disease. And so any synucleinopathy, we get REM sleep behavior disorder. So acting out dreams, that kind of a thing. Okay, and you probably don't need to know this, but we can get this hot cross buns sign here on an MRI scan and some signal changes in the putamen, but that's probably more than you need to know for step one. Now, you should know about MPTP, which is something that, this is individuals that are trying to home manufacture drugs. They're trying to make MPPP, okay, which is similar to morphine, but it ends up being converted into MPTP. And this is very destructive to the substantia nigra. And so these patients look a lot like they have Parkinson's disease. They have asymmetrical tremor, very similar. Interestingly, they respond to medications. Okay, but if the story is this began with trying to manufacture home drugs, then we would think about MPTP. Now, secondary Parkinsonism can occur due to medications, and so I've only listed in terms of neuroleptics haloperidol, but really, hopefully you know all of the first generation neuroleptics and kind of fix those in your mind. Just a really long list of medications, but if the patient is on those and then they start to develop features of Parkinsonism, then it's almost certainly medication induced. The other big category are the antiemetic medications. So metoclopramide is the one by far we see most often, but prochlorperazine or compazine can also do this. So this can cause Parkinsonism, but the medications will often also cause akathisia, the very restless feeling. Patients just feel like they can't sit still. Occasionally, these medications can cause an acute dystonic reaction where the patient has a very dramatic dystonia. It may involve the eyes where they're just fixed and looking up, or the spine may arch and become very rigid. Tardive dyskinesia is usually in women, more often than men that are on dopamine blocking medications. And the key thing here is its lower facial movement and twitches. So if we see that, maybe the tongue is darting in and out, or it's pushing into the cheek, or just recurrent grimacing of the face, that sort of a movement, you'd really want to know what medications the patient is on. Neuroleptic malignant syndrome is something else we can see from dopamine blocking medications. And so this syndrome is caused by dysfunction in the basal ganglia. That gives the patient the rigidity, tremor, Parkinsonism, right? But it also affects the hypothalamus. And so that causes a lot of autonomic instability. And so patients may have heart rate and blood pressure going up and down. They may have a fever. And these patients are sort of agitated, confused. So that's our triad for neuroleptic malignant syndrome. And so kind of the giveaway here is you have to look at the patient's medications. If they're on dopamine blocking medications and you've got this confused, rigid patient with a fever and it doesn't look infectious, your urine studies and everything else is coming out all right, then the patient has neuroleptic malignant syndrome. So this is a clinical diagnosis. It's supported by an elevated creatine kinase because of all the muscle rigidity. And you're going to admit these patients generally, give them fluids, supportive care, stop the dopamine blocking medications. And here are probably high yield for boards. You can give dantrolene, all right, which causes muscle relaxation by blocking calcium release from the sarcoplasmic reticulum. So you relax that rigidity. We can give a dopamine agonist, and so I mentioned we don't use bromocriptine to treat Parkinson's, but it does work well for treatment of neuroleptic malignant syndrome. Okay, while we're on the topic, serotonin syndrome looks a lot like neuroleptic malignant syndrome. If I just skip over here, look at they're also confused, agitated patients. They also have autonomic hyperactivity, so fever, blood pressure instability, tachycardia. They're also rigid. Okay, so the very overlapping features. A big difference here is that patients with serotonin syndrome have upper motor neuron findings. So they have hyperflexia, Babinski sign, and clonus. And then, the key thing is just to, again, look at the patient's medications. If they're on dopamine blocking medications, it's neuroleptic malignant syndrome. If they're on a lot of SSRIs, and that would be the most common scenario, patients on more than one SSRI, or they're also on an SNRI like duloxetine, venlafaxine, or they're getting maybe injections with pain medications like meperidine or tramadol. All of these have an effect to decrease the reuptake of serotonin. So this would be the biggest category. We do see with cocaine and methamphetamines or ecstasy some increased release of serotonin. So this can sometimes be brought out by a patient on an SSRI and they're also using drugs. This really would be very uncommon, but MAOI inhibitors like rasagiline I just mentioned might contribute a little bit, but that's pretty rare. And then serotonin agonists, buspirone would probably be the most important one here. So again, just look at the patient's medication list and we can usually sort that out. All right, so just like with neuroleptic malignant syndrome, stop the offending medications. We'll often give benzodiazepines to kind of relax the patient, get them through this period of time. They usually turn the corner pretty quickly. And we can, in a severe case, give a serotonin antagonist, cyproheptadine. Okay, moving on to hyperkinetic movement disorders. Essential tremor is 10 times more common than Parkinson's disease. So this is extremely common. Unlike Parkinson's, it's asymmetrical, but not quite as dramatically asymmetrical as Parkinson's. But this is a postural action tremor, not a rest tremor. Now, in a really severe case, the patient will have both an action postural and it's so bad they will have some rest component, but it's worse with action. So the patient will say anything they use their hands, it makes it worse. Eating, handwriting, shaving, the hand shakes all over the place. Okay, so it's usually the hands, but about a third of patients will have a head tremor that can sometimes involve the voice. So if you ever listened to Katharine Hepburn talk, she had a very shaky voice. And you want to ask about a family history. So this is found in more than half of patients, and the dad or someone in the family had it. And historically, this is so useful many times. If it gets better with alcohol, patient drinks a beer or a glass of wine and the tremor gets better for a period of time, that's really helpful, a diagnostic clue. So most patients do well. There really are only two medications that are very effective. Primidone, which is an older anticonvulsant. It's never used for seizures anymore. It gets broken down to phenobarbital, but that works well. And propranolol also works well. But remember, we don't want to use propranolol if the patient has asthma, emphysema, or certainly if they have syncopal or, be careful with any cardiac issues there. Now, Huntington's disease, the triad, is of course dementia, which usually starts out with a personality disorder. So the initial symptoms are the patient is irritable, they're getting into fights with people, they have depression. And so usually onset in 40s and 50s. Depression is really common because, this is autosomal dominant, so most individuals have known family members that have it. So actually suicide attempts and suicide success is a real issue in Huntington's disease. Okay, so it's hereditary, so this is trinucleotide repeat, and so you need to know chromosome 4 CAG repeats. And with trinucleotide repeats, we often see anticipation, where it gets worse as the trinucleotide repeats accumulate with successive generations. And this is especially prominent in father-to-daughter transmission. And there we can get a teenager with the onset of Huntington's, and that is due to spermatogenesis. The choreiform movements, which remember are quick, jerky movements, are most prominent for most of the course, but very late this kind of merges into a Parkinsonian dystonia syndrome. Early on, it's quick, jerky movements. And we can take advantage of the fact that these patients almost always have motor impersistence. And that means, for example, the patient's trying to tie their shoes and they just can't keep their hands down there for that activity. The hands keep jerking away. And so on examination, you can just ask the patient to squeeze your fingers, and they can't just hold them tight. They keep letting go, squeezing again, letting go, squeezing. That's called the milkmaid's grip. You can also test this by having the patient protrude their tongue, and they can't just hold it out. They need to keep putting it back in again. All right, so here we have a healthy caudate nucleus bulging into the lateral ventricle, and we can see a lot of atrophy here. No caudate nucleus. The whole brain is affected, as you would expect in someone that has dementia. And so if you had to say more about the pathophysiology, there's decreased GABA in the striatum, which remember is both the caudate and the putamen, which you can't see very well out here. Here's the putamen over here. So I have decreased GABA there. That's an inhibitory neurotransmitter, and therefore we get a hyperkinetic movement disorder. And here at autopsy here, we've got a healthy caudate, putamen, And here you can see a very small caudate over here with hydrocephalus ex vacuo and generalized atrophy. So tetrabenazine is an effective medication for the choreiform movements, and this is a dopamine depleter, and it acts by blocking the ability of dopamine to get transported in to the synaptic vesicles. It works very well. The biggest downside is it can cause depression, and since depression and potential for suicide is such an issue for Huntington's, that can be a limiting factor for treatment. So here's a summary of our trinucleotide repeat disorders. And these are the three we've talked about in the highest yield, I would say. So Huntington's, remember myotonic is chromosome 19, CTG repeats. Friedreich's is on chromosome 9 with GAA repeats. Hemibolismus is another hyperkinetic movement disorder we've talked about here, a stroke in the subthalamic nucleus. So this is a sudden onset problem, as any stroke syndrome is, and so the ballistic movements are on the opposite side of the body. Tourette syndrome usually occurs by the age of 11, would always occur symptoms before the age of 21, and so these are multiple motor tics and also vocal tics. The vocal tics are just quite suggestive of Tourette's. So throat clearing, clicking sounds in the mouth, recurrent sniffing, those kinds of things. More common in men, about half of patients resolve by the age of 18. And then you need to remember the attention deficit hyperactive disorder, which is really common, and obsessive compulsive disorder, which can be really profound in patients that have it, is seen in 30%. Okay, I'm not going to go into treatment. I don't think that's high yield for step 1. Wilson's disease is another hyperkinetic movement disorder, and we would always want to consider this easy to check for in any young patient that presents with a movement disorder. So remember, this is a problem with copper deposition, okay, and it can deposit in the liver, so some patients will present with liver involvement, but if it deposits in the basal ganglia, then the patient presents with a movement disorder. And so this is usually with a tremor. Now, the other types of tremor we mentioned, like Parkinson's, essential tremor, it's mainly down in the hands. It's a distal tremor. Wilson's disease, it's a proximal tremor. We call it a wing beating tremor. So that's a bit unusual. They may have a dystonia. Okay, so maybe the foot keeps turning in or the hand keeps going into a kind of a cramped posture. Slurred speech is extremely common in Wilson's disease. They have muscle rigidity, and frequently they have a psychiatric manifestation. So maybe depression, delusions, anxiety that goes along with it. The other place that copper deposits is in the cornea, and so they get Kaiser-Fleischer rings. And so the pathophysiology of Wilson's is we have these ATP7B mutations, and these produce the ATP7B protein that is a copper transporter, and we see that here in the liver, and it's also involved in the brain as well. Okay, so the copper doesn't get broken down normally, and this ATP7B mutation is also involved in the abnormal brain deposition. Remember the Kaiser-Fleischer rings, okay, that we can see here. Okay, so you may want to send a patient to ophthalmology if you're not, to really get a definitive answer on that. And if we think about Wilson's, we'll do a 24-hour urine copper, which would be elevated. And then we can also measure a serum ceruloplasmin, which will be low. Now, in terms of dystonias, you probably, for now, just need to know about the idiopathic dystonias. So blepharospasm is recurrent eye closure. This is always bilateral. Okay, and so this is the orbicularis oculi. It's often stimulated by sun or the wind, and patients have these spasms of eye closure. Cervical dystonia or torticollis is twisting head and neck movements, so sternocleidomastoid, splenius capitis, other muscles are involved there. Spasmodic dysphonia is of the vocalis muscle, and so if the patients have a constrictor type of this, then they have a tight, choky voice. If they have the adductor type, then the breath becomes the voice becomes very breathy and soft. Okay, and writer's cramp is an example of a task-specific dystonia, where the hand is pretty normal except when the patient tries to write, and then the hand goes into a dystonic, kind of a clenched posture. So all of these idiopathic dystonias respond very well to botulinum toxin injections. So for blepharospasm, we can just inject the orbicularis oculi. For cervical dystonia, we inject the neck muscles that are involved. This works really well, and patients have about 3 months of good improvement, but then they need to keep coming back because it wears off. Okay, so last slide here, the synucleinopathies. In this lecture, we talked about Parkinson's and multisystem atrophy. Okay, in the dementia lecture, we'll cover dementia with Lewy bodies. So remember, we have Lewy bodies and Parkinson's, but in dementia with Lewy bodies or diffuse Lewy body disease, they're seen throughout the brain. And so with a synucleinopathy, all three of these conditions have REM sleep behavior disorder. Okay, tauopathies, the only one we covered in this lecture is progressive supranuclear palsy, but I'll remind you of this in the dementia lecture, that frontotemporal dementia and Alzheimer's disease also involve abnormal tau.